Good evening, everyone, and thank you for joining us. I'd like to welcome you to tonight's program, The Importance of Composite Adaptation, presented by Dr. Lori Trost. This webinar is made possible through the support of Dentsply Restorative. Dr. Trost receives an honorarium from Dentsply Restorative for the preparation and delivery of this presentation. Dr. Trost will present for 45 minutes, followed by a Q&A session. You may type any questions or comments you have for her in the control panel on the right-hand side of your screen. You may also send a chat message to the staff for any technical support questions you may have. This program is eligible for 1C credit, and instructions for obtaining the certificate of attendance will be emailed to everyone after the program has ended. Dr. Trost maintains a private dental practice in Columbia, Illinois that merges contemporary aesthetic dentistry with a minimally invasive approach to patient care. Her practice and team pride themselves in utilizing the most current technology and continuing education, both in patient care and treatment options. Dr. Trost has authored over 50 articles relating to dental procedures, techniques, and materials. She also actively participates in clinical research and consults for the top dental companies in the field. So without further ado, I would like to turn the program over to her. We hope you enjoyed the presentation.
Thank you, Lisa. And welcome, everyone. Just a little bit about me. I am a full-time practicing dentist in Columbia, Illinois, just right outside of St. Louis, that focuses on restorative dentistry as well as a lifelong learner. I'd like to take this opportunity to thank those that are responsible for the program right now, and that's Catapult and also Dentsply Restorative. I would also like to disclose that although I have no personal financial interest in any of these products, I am receiving an honorarium for this program. All the procedures, products, and photos used in this program are supported by the literature and also used in my practice. If you have any questions during the program, please type them in the questions box, and I will be happy to answer them at the conclusion of the program. With that, I consider this a privilege to share time with you and to show some practical and clinical opportunities. Direct composites continue to dominate a large sector of our everyday dentistry. And then, although they're effective and composite placement requires careful selection of materials, and of course it requires meticulous technique, it has to be coupled with the time for a true successful outcome. With the evolution of dental materials, specifically bulk fill materials, the emphasis has shifted to maximizing properties that offer clinical efficiency as well as effectiveness. We often take for granted restoring a simple Class 2 slap prep like you see here. The success of this restoration is more than just filling the hole. Rather, the importance of how the composite adapts to the detailed adhesive interface will be the key to how long the restoration succeeds. Here's a great example of a slap prep that was initiated, and after the decay was removed and to open the contact, decay extended to somewhat measly and was removed with a large round burr. You can see here how the prior restorative materials would have dictated that more tooth would have been required to be removed for access, and a larger extra restoration would have been required. However, with now current adhesion dentistry and with a specific cavity geometry, we can use materials now that are truly suited to become and remain conservative. I'm confident that the material that I'm going to select and place and restore into this preparation will have a great outcome, and it will be radiographically sound, as you can see there in the picture on the right. In a nutshell, this program is going to discuss 3 basic components that influence adaptation. You'll learn intimately how each of these components play significant roles in every restoration's outcome and longevity. You're going to gain a good understanding of material properties, specifically how polymerization stress and volumetric shrinkage affect composite performance. I'm going to talk a little bit about what bulk fills are on the marketplace today and the key properties that differentiate them. And finally, we're going to talk a little bit about specific vulnerabilities that lead to failure. Ultimately, I want to be able to offer practical solutions from good material and technique choices based on sound clinical research to improve patient outcomes. Have you ever considered how important a foundation is? I'm talking about that substructure under a house or a building. We all live somewhere, work somewhere. You probably take for granted how strong and secure the substructure is until you start to see signs that something has shifted. These small imperfections, such as a void, crack, or separation, can evolve into something bigger. and more complicated. And when that happens, everything above the foundation is at risk. The integrity of the first layer becomes central to what is really placed above it. It's imperative that the base or foundation must be well adapted and secure. The same applies for composites. If the integrity of the foundation or additional composite layers become compromised, such as a void or perhaps too much stress, the results that we see clinically extend from top to bottom. At the top, we may see marginal staining, decreased wear resistance, discoloration, micro-leakage, debonding, or even secondary caries. Consequently, the pulp may become insulted and the patient may complain of postoperative sensitivity. Ultimately, the restoration fails. The ADA came out with this statement in their product review. And they said the most common causes for postoperative sensitivity, and here they completely list what is happening. Each of these, and when you think about them further, directly relate to how these materials that you're going to use adapt. They're talking about polymerization, shrinkage, and stress, incorporating and adapting that material so it can properly cover, and of course, undercured material. So what influences adaptation? There are several things we need to consider. There are three main ones. Physical properties. These physical properties are polymerization, stress, and shrinkage of the restorative materials. Then you need to consider the adaptability or flowability. That's the process of how the material intimately flows into existing preparation geometry. And finally, we're going to talk a little about light curability. It has complete influence on adaptation. How well does the material cure? What depth does it cure to? The bottom line is no matter what restorative materials you place individually or in combination, these three components will influence every restoration that you place. From their chemical compositions, dental composites volumetrically shrink. Some shrink as little as 1.5%, others up to 5%. Shrinkage is the process of volumetric contraction that occurs when the curing the composite happens. Materials that possess high shrinkage values can create voids, marginal discoloration, secondary allow for postoperative sensitivity. Obviously, you want to make sure that you select materials that contract or volumetrically shrink as little as possible. This illustration gives a great visual understanding of what happens during polymerization. As a composite cures, we know that there's a volumetric shrinkage that occurs, but also a physical stress translates on or within the tooth. Essentially, stress becomes the force that the shrinking composite exerts on the surrounding tooth structure. Think for a moment if the material is insufficiently polymerized or is an inadequately cured composite material. This then becomes a significant violation of the foundational integrity that I was just talking about. Physical and chemical properties of the material you relied on are now adversely affected, allowing for a weaker restoration, weaker properties, sensitivity, and decay. And then if you also consider if the material is not properly adapted to the preparation geometry, again, you've violated some key points here. The lack of foundation integrity compounds the risk. Relating this clinically, we can better understand that the restorative interface is constantly subjected to stress and strain imposed by polymerization shrinkage forces, as well as then thermal stimuli and then, of course, functional occlusal loads. If the polymerization stress becomes high enough, it can cause cracking of the tooth structure upon light curing due to the resinous shrinkage, like you can see here in this example. Adhesive fractures may also occur, and that's called debonding. In extreme cases, the tooth may even fracture. Here's a close-up view of a high-resolution image of debonding itself, and you can see how the composite has pulled away from the adhesive interface during the polymerization. This illustrates that the stress that's created on that bonded surface has now become at risk. So technically, the interface of contraction is really placing a lot of force, and that stress is really what relates and creates that bonding effect. The configuration factor, or C factor, is another thing we need to consider. And this is an estimation of stresses that's generated by given cavity configuration using the ratio of bonded to unbonded or free surfaces. The higher the C factor, the higher the stresses that are generated. You can see here in this example of Class 1 cavity preparation, you have 5 bonded surfaces versus 1 unbonded surface to create a C factor of value of 5. A Class 5 restoration also has a C factor of 5. This indicates that Class 1 and Class 5 restorations can generate the most stresses on the tooth. Kind of putting this into a Class 2 restoration here, you can see you have 4 bonded surfaces versus 2 unbonded surfaces to give you a C factor of 2. And on this timeline that you can see here, and actually value line, you can see here the low stress up to the high stress, so Class 4 would have the lowest stress or C factor representation of 0.2. So then you can kind of understand a little bit about how that factors. You'd have 5 unbonded surfaces versus 1 bonded surface to get that number of 0.2. If careful technique is not used to produce and reduce polymerization stress, you're going to get a negative outcome, and this can really result again and reflect as post-operative sensitivity, micro-leakage, secondary caries, and even a factor of debonding. The second influencer is adaptability, essentially how a material flows into a defined space. It's about the material's ability to conform to its confines. In other words, thickness and the ability to self-manipulate or adapt becomes central to the material's placement. As you can see here, you have a self-leveling material on the left side, and on the right you have a mound. As the viscosity drops, the adaptation to the cavity surface increases. The example on the right clearly requires manipulation. The chance of air entrapment, contamination, or voids becomes a certainty. I want to ask you, how do your materials handle? Do you need to manipulate them when you're placing them? Do you worry about voids or slumping? Are they sticky? It's no wonder that doctors routinely find stickiness to be the number one detriment when they're selecting and working with a composite. To increase marginal adaptation, especially for a Class 2, 90% of dentists now report that they use a flowable as a liner or as their foundational layer. Given this acceptance level, the flowable foundation must not only provide excellent adaptation, but also possess low polymerization stress and be able to be thoroughly and radiographically sound. The final component that influences adaptation is light curing. Clinicians should remember the following basic principles ensure adequate light curing of composite materials. Deep composite resin restorations demand a high-quality curing light. You need to have good operator technique, and you need to make sure that the ability of the light is directly placed into the preparation as close as possible. You need to also provide sufficient curing time for every individual type or shade of material. Pay close attention to the depth of cure that manufacturers make. Most bulk filled composites on the market today claim a 4 millimeter depth of cure. I'm going to show you a little bit here how some of that value can change, but there's a lot of ways this can be affected, and maybe that 4 millimeters is really not as true as what you would think. And when I look at this line here that's going to come across here, this is a 4 millimeter level increment, so you need to really consider how your light is affecting the depth of cure, the base of that proximal box. You need to understand what could be above that. Is there a ring? Is there a matrix on a Class 2? So there's a lot of components to really consider. Also, if you're using a halogen light, make sure that you double the time for curing. As you can see here, not all curing lights and beams are created equal. Take a good look at your light and see how direct and collimated your beam is. You need a good focus for good curing, and especially need a good quality curing light when curing the proximal box or bulk materials. Always remember, a bulk fill requires a bulk cure. One of the most challenging aspects of any restoration is delivering enough energy to light cure the resin composite in deep preparations. All curing lights experience an energy drop-off that decreases the amount of energy delivered to the restoration over distance, and the amount of energy lost varies among curing lights. And you can see here, this is just a graph that shows various lights that are out on the market today and really how they perform. and you can kind of see from the different colors which lights you're using. Hopefully yours is listed up there. Hopefully it's a good performer. If it's not, I'd really evaluate what light you're using, because you might have a great placement technique, great meticulous adhesive technique, but yet your light might not be helping you arrive at the best optimal restoration necessary. So again, critique every kind of step you're doing when you're placing composites, and I think looking at a good curing light is really sound advice. This is another good example of why light curability is so important, because if it's not cured, it won't become as radiopaque. And besides that, the material itself needs to form in a radiopaque value. Some flowables are a lot more radiolucent than others, and it makes it very difficult to judge voids or recurring decay. So again, look at your materials and see what you have and how they perform. What do they look like? Here's a great test you can simply do yourself. Do it tomorrow. Take a conventional flowable and just take a regular radiograph and place the different flowables that you might use within your practice, and go ahead and express those and then develop the x-ray and see how they look radiographically. Conventional flowables have been inferior in key areas of wear, shrinkage, and strength by clinicians, that they find the flow and ease of handling, and they consider these things, and they say, okay, which one flows better and easier, but maybe radiopacity-wise, it might not be the value that you need. So it's really, really important to know the materials that you're working with are performing and how you expect them to perform. The takeaway here is basically some of these flowables have limitations. Besides their material properties, their viscosity might be too high, or they might not be properly, allowing them to be properly adapted. And this is a really, I'd say, gross example of a radiograph of a patient who came recently to my practice, and there's so much diagnostic uncertainty here about what materials were used, adaptation-wise, secondary caries, that you really concern yourself about what materials are out there. And I've been practicing long enough to know that early on, flowables were not necessarily as radiopaque as what other materials are that we currently use today. And that question becomes, what are you using literally underneath these composites? How is that adapting? And what is that going to look like radiographically when it's a final outcome? What's it going to look like in a year, 2 years, 5 years, 10 years, and so on? So it's really critical to know everything you're placing there has great adaptation and it's radiographically sound, so there's zero uncertainty. Here's another test that you can take. Take your periodontal probe and measure the value and the width of your curing light. If the average clinical crown height of a posterior tooth is 6 to 8 millimeters, clinicians may be faced with a little bit of challenge today to make sure that that light can adequately cure into a deep preparation, because there's definitely a significant difference from the curing light tip to the base of that proximal box. Given that the average class 2 depth is 6 millimeters, and then, like I was talking about earlier, you add on a cuspal deflection, maybe a matrix or a ring system, that height can easily jump up to 8 millimeters. So without a complete cure, again, the restoration is going to fail secondary caries and, of course, post-operative sensitivity. And we certainly don't want to have patients having that. Composites take a lot to place, and you want to make sure that when you're doing it, they're going to leave with the adequately, properly cured restoration. In this example that I'm showing you here, I'm using a smart light, and I'm showing you the width of this, and you want to make sure that your beam is able to measure. And again, this light, when you're considering curing a molar, you're going to have to move. If you're going to think you can get the entire molar width of that, let's say perhaps maybe an MOD restoration, you're not going to be able to do that. You're going to be able to cure one aspect of that proximal box mesially and then move to the distal or vice versa. So it's really something you need to be concerned about, because the combination of that beam is the actual width. You need to make sure you measure and you know that you have your proper light curing, proper distance, proper width, proper placement. So where are we today in the marketplace? And where have we come from, and where are things moving to? Traditionally, composite resins have been placed in increments no greater than 2 millimeters. This 2 millimeter increment allows for adequate photopolymerization of the composite resin that really lessens the polymerization stress that's associated with composites. The thinking here is by reducing the volume of the composite that's polymerized at each placement stage, you maximize the conversion of monomers to polymers. The first layer was thought to wet the surface for adaptation. Most frequently placed in a Class 2 restoration, the gingival box and occlusal floor was a thin flowable layer, like you can see here in the yellow on the diagram here. Remember, flowables are notoriously guilty of shrinkage because they're less filled. So the initial layer was about 0.5 to 1 millimeters in thickness. Next, increments of 2 millimeters were layered and cured. Each layer allows for the proper light penetration of the photopolymerization. However, the possibility of voids, contamination, and the time required to place these restorations are a disadvantage, and they're somewhat limiting. As you can see here, I've got listed the pros and the cons of incremental layering. And certainly if you've been placing composites long enough, you probably have come from this type of technique or application. The pros, obviously, the wetting layer, you're going to have good adaptation by completely placing that flowable. And then as you incrementally build your restoration, you know that you're able to adequately cure and convert through the polymerization process. But those steps also can welcome some challenges. You can incorporate voids. There could be air voids. There could be bubbles. The time that it takes, contamination is tough. Keeping patients still, keeping things isolated is tough. So again, several steps versus a good outcome. You have to sit there and weigh this out. And if we could use materials maybe that could be a little bit more effective and a little more efficient, I think it's a win-win. The development of bulk fill materials answers directly to the clinical challenges we face today. Bulk fill materials provide dentists a simpler and faster application when compared to the 2 millimeter conventional incremental composite layering. As we've established, flowables have been notoriously guilty of shrinkage. However, bulk fill materials have been specifically designed to decrease the polymerization shrinkage and stress on the tooth structure due to their modifications in their chemistries. Why the bulk fill trend? Besides reducing the restoration time, bulk fill materials possess a self-leveling effect and adapt nicely to cover all the surfaces, lessening any chance of voids. This in turn reduces the postoperative sensitivity. Essentially, bulk fills have become the dent replacement in a single increment. They are placed in 4 to 5 millimeter increments and light cured adequately for 20 seconds. The ideal bulk fill will have all of these qualities and of course be easy to place and have easy access to be placed. They're going to have low stress, flowability, certainly self-leveling. You don't have to manipulate them. And they're going to have excellent radio opacity. Super critical to make sure that you have that happen. Bulk fills in the market today are offered in 2 viscosities, high and low. As you apply what we've been learning here and talk about the flowability, the high viscosity formulations can sometimes be difficult to get adequate adaptation without a flowable liner foundation. Pay close attention to the shrinkage stress because it varies between materials, and some may have unacceptable levels which may compromise that integrity of the restoration or that foundation. Also be careful with different bulk fills to make sure the depth to which these materials can be properly and thoroughly cured. Very, very important. Again, always read the directions and instructions from the manufacturer. Look at scientific data and literature. Make sure that you see and what you're using works, because the measurements of that research really pay off clinically when we're doing everyday dentistry. There are lower viscosity bulk fills offered that permit good adaptation as well. Most of these materials reduce shrinkage and require capping or a occlusal layer like you can see here in the diagram. Care must be taken to know the depth of the bulk fill placement. The difference in these low viscosity bulk fills is in their performance. Here's where the science and that research, like I just talked about, becomes so really very important. You want to use material that provides the best chemistry, offers physical properties, and allows that ease of clinical placement. Again, these are different materials that are out there on the market today. I've used several of these. They work very well. The big key, I think, to working with a bulk fill is not violating that first increment. You need to know if it says 4 millimeters, then keep it at a 4 millimeter level and placement. Don't violate that placement increment, because then the curability, again, you're going to violate what the depth and what the recommendation is. That can ultimately fail that restoration's foundation, like we talked about. Here's an example here of a low viscosity bulk fill. You can see here the access of the unit dose that I'm placing here and how this material flows. When you're working with these materials, it's really nice to place this down into the the depth of the proximal box. You can go ahead and start to express this, and it starts to flow and adapt and flow very nicely and mound up. You don't need to swirl it around or really coat. If you can just kind of express it, it starts to place and starts to flow nicely. And I find that I don't need to take any kind of instrument to it. I can go ahead and place it, allow it to self-level for several seconds, and then it's ready to be light cured. I don't have to take an Explorer to it. I don't have to take a anything else like that or any kind of instrument. I just allow it to place and allow it to settle and self-level. And I think that's truly critical because, again, I don't want to welcome any kind of contamination or create any kind of void. Let these materials flow and use them for what they're meant to do. It's also noteworthy to say, hey, these materials can also save about 40% of your placement time too, because of the depth of cure and how they can be placed. So it's truly a win-win with easier placement, I believe, a good solid product, and reduced polymerization stress, as well as more efficiency. So I think they're very effective and they produce a great result. As you can see here, this is a polymerization shrinkage stress graph here, and you can see which materials kind of line up, and whatever your material you're using, you can kind of see the values. Obviously, the less or the lower the shrinkage stress, the better for that material. Materials that contain higher stress or are more viscous could compromise that bond. This diminishes the chance of higher forces on the bond, and you can become more confident that gaps don't form. I want to talk a little bit about the consequences of light curing, and this is really, really critical. The number one failure for restorations is lack of a properly cured restoration. You can see here in 2002 the ADA came out and found that 37% of composite restorations were insufficiently cured. That's monumental. I think we're better than that, and I think we need to really drop back, look at the science, and I think there's probably two reasons for that. One is the type of material, and two, perhaps the quality of the light. So again, going back to having a really good light, very, very important to have that, and having a good light curing technique. And I'm going to go a little bit into depth about that because it's super important to have. If you're going to place a great material, it's got to be properly cured. The consequences of this are really relatable. I mean, patients are going to come back, they're going to have post-operative sensitivity. For all I know, that x-ray that you saw just a little bit ago could have had insufficiently cured composites. And you can see how they wash out, how they lead to secondary caries, and obviously a weaker restoration and a very unhappy patient. And it's sad that you take a lot of time to place something and then you find out that your light's really not working or your technique is not as good as it could be. So use a good quality light. Take the time to absolutely really use a good curing light technique. You want to cure from the buccal and you want to cure from the lingual, and we'll talk about that here in just a little bit clinically as you see a couple of the cases I'm going to show in just a bit. I'm going to move on to some of those clinical cases that show how well these materials do adapt. Here's a very traditional presentation of quadrant dentistry. The patient presented with an amalgam on her first molar and occlusal decay on her second molar. When you remove this existing amalgam, often the cavity geometry is very undulated. For me, the flowable base that I'm going to select becomes so critical because I'm going to rely on its ability to adapt into those cavity surface nuances. After initial decay removal, I use a caries finder liquid or solution, and then I'll go ahead and remove any remaining decay with a large round burr. Next here I'm using a selective etch technique where I'm going to place a 15% phosphoric acid, and I'm going to rim just the enamel framework, and I'm going to let that stay on there for 15 seconds. And I'm going to go ahead and follow that by a nice steady rinse of 10 seconds. I always want my dentin to remain moist. Next, I'll blot the preparation completely with the 2% chlorhexidine and allow that to remain on there for about 1 minute. I'll lightly suction that, and then it's time for the adhesive application. And in this case, I used Prime and Bond Elect. When you apply an adhesive, you really need to follow the instructions of the manufacturer as well, not only for the time that you're going to place the adhesive, but also the application recommendation. This is a selective etch. It's a universal etch, or rather universal adhesive, and in this case it needs to be scrubbed. So I'm going to go ahead and scrub the entire preparation for 20 seconds, and I'm going to use a clean micro brush. I'll have my assistant actually put a fresh drop of Bond adhesive directly onto that brush, and I take it straight into the preparation, and I will scrub and cover all of those surfaces. I don't want to scrimp on time here. It's got to be completely 20 seconds. I'll then take my air syringe. I'll clear any kind of moisture or any kind of water. I make sure the line is completely clear. I'll kind of start to use the air I'll spray into a cotton roll, and I'll drag it across, and I'll kind of do a zigzag and a stream of air motion over the preparation for about 3 to 5 seconds until there's no more ripple, or you don't see any kind of movement whatsoever within the preparation, and then I know that my adhesive application is ready to be light cured. On that last slide too, that I want to make a point, we do use disposable air tips for that reason, because we know that we have fresh product there every time we're using rather air or water in those. So I think that's a really critical thing too. We really fine-tune our technique that way. I do want to reemphasize that importance of light curing and how it influences adaptation. And your composite curing will only be realized with good light curing. Here, it's critical to have the light be as close to the preparation and needs to be perpendicular. If it's angled, you can see here with the red arrows, it's going to have a red triangle of, it'll be missing some areas of that preparation that need to receive that energy from that light to properly cure and to properly photopolymerize. So with any kind of technique, you need to make sure that it's steady. Use finger rests. Approach from the occlusal. Also make sure you go from the buccal and the lingual. Angle that correctly so that it can go as close as it can on especially class 2 to the gingival proximal box, and keep it steady. Make sure that for deeper restorations you're going to increase the curing time as well as if you have any darker restorations, darker composites, they require a little more time as well. I do like to air cool or wait a little bit between the cycles of curing. I'll often cure the occlusal and then wait a few seconds, and then we'll approach from the buccal and get as close as we can, again, for a class 2 along the gingival, buccal gingival aspect to get to the proximal box, etc. So again, wait a little bit of time, let things settle and rest, and then go ahead and continually cure and make sure that all aspects and all surfaces have received that light energy that need to activate this material. Also make sure the tip of your light is completely clean, and measure the output of your lights. Very, very important. Easy to do. Just have your assistants do it. It's not that hard. In this example here, I'm using SDR, Shearfield SDR. It's my bulk fill foundation layer choice, and I've got a lot of confidence in this material because, one, as you saw earlier in the graph, it offers the lowest stress available in the market today, which is it beats every other bulk fill out there by about 60% less polymerization stress than other flowables, and I'm really super confident in its ability to not only adapt but provide the proper physical chemistry that I want to have in a successful restoration. It's probably one of the most researched and clinically proven materials ever on the market, and I really just have a lot of confidence. I use it daily and routinely, and I'm a true believer in it. Recent enhancement of the material offers now a higher wear resistance and increased radio opacity, so that's a win-win too for visualization on x-rays, etc. You can see here it's offered not only in a unidose variety, but also in a syringe application method too. We personally use unidose in our practice, and we find that that's probably the easiest and most successful in how we work with it and use it every day with composite placement. I'm going to show a video here next a little bit, so wait for the, if you can, just a second. You're going to see how nice this can work and how it really does nicely.
Sure-fill SDR flow, the only bulk fill self-leveling posterior flowable. Begin dispensing at the deepest part of the proximal box. Sure-fill SDR flow not only adapts to the matrix band, but to the internal anatomy, including the sharp corner of the proximal box. As we move across the prep, the material is not pulling or dragging, but moving along with the copula tip. After placing the material up to 4 millimeters, it quickly levels to provide a smooth interface to adapt composite to, even when you're performing maxillary restorations. To demonstrate, a human molar was prepared for a large Class II restoration. The tooth was cut in half and adhered to a standard glass slide. A matrix band was placed to seal the proximal box. The glass slide was positioned at a 45-degree angle to mimic a maxillary restoration. Begin dispensing at the deepest part of the proximal box, and watch as sure-fill SDR flow self-levels and adapts to the corners of the prep. After dispensing up to 4 millimeters, sure-fill SDR flow remains where placed and does not slump or flow out of the cavity preparation, making it ideal for use in maxillary posterior restorations, self-leveling, and bulk fill. A revolutionary posterior flowable composite any way you look at it. Sure-fill SDR flow, the only bulk fill self-leveling posterior flowable.
Here's a case moving forward here that I've placed TPH spectra, and this is actually a low viscosity. I've gone ahead and sculpted this in a B1 shade, and you can see here before we move the rubber dam how close I try to get my anatomy when I'm sculpting and when I'm working with these composites. We'll remove the rubber dam and then go ahead and adjust occlusion, and then finalize and move on to polishing. And I'll use an enhanced polisher there too, and you can see how that is. And here's the final view of both of those restorations. And I'm pretty happy with that, and patient was thrilled with that. Nice look and great function. More importantly, I think a very sound end product for her as well. Here's another case. A patient presented with decay on the second, or rather on the distal of the first molar, I should say, and it necessitated direct composite restoration. A trick that I like to use a lot of times when we're doing Class 2s, before we even start, we'll floss the to see exactly what type of contact we need to restore. And I think that's just a really good way to measure that joining, that interproximal surface. A lot of times contacts are not even existent, and we're trying to restore something that maybe is really difficult, so we're trying to expect more than what we can really deliver. So do yourself a favor, start off with flossing that contact, and you kind of get an idea of what you're going to work with and what you need to restore. Next, I'm going to take a 330 Midwest carbide burr. I'm going to go ahead and prepare the distal occlusal surface of the tooth, and again use a Carey's solution, indicating solution, and discover any kind of remaining decay, and use a large round burr to remove that as well. You can see here how that preparation is going to look, and where we're at here, and I'm using a number 2 and a number 4 round burr there as well. Next, to isolate this patient, this was a challenging case. The patient was a gagger, and I know that we work with patients who it's difficult sometimes not to be able to use a rubber dam or use different types of isolation gadgets that are out there on the market. So in this case, we had to work fast, and we had to work, I think, with great isolation as best as we could. So you won't see a rubber dam with this one. You're going to see cotton rolls, and we were able to pull this off and keep it isolated. We're using a Paladent Plus sectional matrix, and it has a nice subgingival molar matrix band that goes and drops really there to below that gingival box, and it really helps to seal that. So we're using proper suctioning and really good cotton rolls to really help dry this and keep this to create the optimal clinical result, because this was a tough case. You can see here the value of, again, another good clinical study. This is an ADA clinical brief that came out in 2014, and it's really important as you look down the list here of different materials that are listed they talk about what the manufacturer's claim is, and then the ADA did their study, and they found out what their measured depth of cure was, and you can see how those values compare. And whatever kind of material you're using, I think it's really critical that you use this type of science to really bring that into your practice and to know and have confidence in the materials you're placing, because this is truly clear that certain manufacturers might make a claim that maybe it doesn't really say exactly and tell you exactly. Maybe that's not what clinically the research comes out to be. So again, match the performance with the clinical research, and I think you've got a win-win. I just think there's discrepancies that really need to be sometimes identified, and you need to, you want to tweak your clinical expertise. This is how you do it. You really dig into the literature, and you see what materials truly measure up. Another trick I like to use a lot of times, we'll take a periodontal probe and we'll measure the depth of that proximal box so that we know exactly how much bulk fill material we're able to place and to what depth. And you can even use like a little rubber gauge, an endo gauge that we use a lot of times here, and you can place that even on the tip of that bulk fill material syringe, unidose, and you can see and you know exactly where you're measuring, exactly the depth of placement. Because again, you don't want to violate that depth of cure rule. This is a graph that illustrates how various curing lights perform over distance, and of course better curing lights will provide more energy over the distance. This relates completely to adaptation in that the material will only be as cured as that curing light will allow. So again, that bulk fills need a bulk cure. Really, really important. Here we're going to go ahead, and a selective etch technique was used, carefully applying the 35% phosphoric etch gel for 15 seconds. We're going to nicely rinse that for 10 seconds, continually keeping the entire preparation moist. We're going to do a chlorhexidine blotting pellet. We're going to go ahead and lightly suction that off, and then we're going to apply our adhesive, and in this case I'm using Prime and Bond Elect Universal Adhesive. It's probably one of my favorite bonding agents. I think it works very, very well. It can use and be used in a variety of methods. It can be a self-etch, selective etch, or total etch, depending, I think, on the anatomy of the preparation you're going to work with. And I just find it to be a really go-to adhesive for most of the things we use within our practice. We're going to go ahead and apply that for 20 seconds, follow that by a nice thin stream of air for approximately 2 to 3 seconds. Again, you don't want to have any kind of rippling. You want to make sure that it's completely steady and glossy, and then go ahead and light cure that for 10 seconds. Again, look at that semi-gloss appearance, and then you know that you're ready. I've got that light completely on top of that restoration finger rests and properly curing it. Here's the bulk fill material that we're going to go ahead and use is SDR. Sherpal SDR, and you can see how I'm delivering it to the base of the proximal box. I'm going to place that, I'm going to go ahead and express it, and you can see how it starts to self-level itself and come up and really adapt very nicely and cover, and actually went across and covered about a millimeter of the pulpal floor as well. And I did all of this without any type of manipulation. I find the advantage of this bulk fill material is to provide the excellent adaptation that it does, and it really helps my confidence in knowing that the understory that I'm going to create, that final 2 millimeter composite capping layer, is very, very sound. I think it performs efficiently, and it doesn't sacrifice quality or cut corners, and that's really, really important. All of these products, I think they need to be used wisely, and you certainly don't. Efficiency is not cutting corners. You got to remain effective, and that's what I really want to come across and really talk about, because efficiency and effectiveness they go hand in hand. Here I'm going to go ahead and light cure this again for 20 seconds and make sure that's solidly cured. After I take off that ring and the matrix, I will go ahead and will cure from that buckle aspect into the gingival, or I should say the gingival box, proximal box, and then we'll also let that rest for a bit, and then again approach that curing from the lingual aspect into the gingival box as well. These are the two tools that I routinely use for every composite placement. I've essentially pared down two tools into one and created a combination tool of the Friedman duck head and as well as the Ladmore 3 burnisher. I use this tool to pack and smooth and kind of use the cone burnisher end to create anatomy. The other instrument that I always go to is the Nordent curved as a flexible blade, and I find that I'm able to smooth facial and buccal aspects of restorations as well as round marginal ridges, which is really critical to the success of Class 2 composites especially. You can see here from the study how important it is to round marginal ridges. A lot of times they can fracture or chip. You can spend all the time on them. The patient goes out and might bite on one thing. Well, it's just because it didn't have enough proper supported composite or it wasn't a rounded marginal ridge. So save yourself the headache and time. Round your marginal ridges and make sure that you have a nice, steady, flowing ridge that goes into the occlusal aspect and good anatomy, and reduce that heavy localized occlusion because you'll have a better wearing, a longer life, longevity, especially in a Class 2 composite. Here I'm doing a final capping increment of 2 millimeters. It's a universal composite TPH spectra. We're going to go ahead and place this, and the composite's basically sculpted, and you can see here I'm rounding this out and using those tools I just talked about. And I like to really establish that anatomy as close, like I talked about earlier, to the original tooth surfaces as well. I like to take the extra time doing this because I feel that that actually saves time and it really spares unnecessary enamel removal with a carbide down the road if you're going to be adjusting occlusion. So take the extra time and really finesse your sculpting ability, and I think you'll have a win-win. You can see here I'm going to go ahead and I'm going to use that Norden tool. I'm again sculpting, packing, and then rounding that marginal ridge for that improved contact, support, and cleansability. And finally here, we're ready now for finishing, and we're going to adjust the occlusion, see where things play out at. Then I'm going to use, I use basically the 3 same burrs routinely on this. I use a number 4 carbide, a round carbide. I use a flame-shaped as well as a small football. And I found that by keeping things simple, you just can routinely go to these and really learn to master them in your routine and your technique. Here's the completed restoration, and then I'm going to go ahead and use an enhanced polisher. I really like these. You can use these on a very intermittent light touch in a dry field and just create a nice luster, and you just kind of lightly touch and slow speed these, and you can really get a nice polish on these restorations. And the patient was very pleased with this result. So let me ask you, why do you need to adapt? What is adaptation? The answer to me is very simple. I think if you want to achieve restoration longevity and do the right thing for your patients, you need to select materials that really provide this. Fundamentally, posterior composites are becoming more efficient, and resin placement protocols are becoming more predictable due to the improved material properties. As resin chemistries continue to advance, clinicians must find the means to leverage restorative materials and techniques to provide their best outcomes. So again, these are simple steps. Choose good materials, look into the science behind them, and see why they work clinically. Use just good common sense. Use good light curing. Don't violate the limits, and select a proper occlusal cap if, in fact, you're going to use bulk fill materials. Ultimately, we just want to provide the best outcomes for our patients, and I think if you commit to that, it's a win-win for your practice, and you'll certainly have patients referring to you for doing just really excellent, good work. Thank you for participating in this program, and if you would like to get a materials list of all the products that I've mentioned in this webinar, you can feel free to email me at trost@htc.net. And if you have any questions, I would love to answer those right now. And for continuing education, you can remain on the program here, and there'll be a queue for your CE credit.
Everyone, if you could just take a moment, this will be a good time to ask Dr. Trost any questions that you have. You can go ahead and type them into the chat box. And Dr. Trost, let's wait a minute here and give everyone a moment to type them in.
All right, I'm getting some excellent questions here. The first question here comes from Ray, and he asks, how do you ensure a tight contact with this flowable material? Absolutely great question, Ray. I think the contact has to be formed from the matrix. And what's happened is over time we've moved from obviously placing amalgam and using a Tafelmayer, for example, matrix, and we were used to using a packing motion to place that amalgam against that matrix in order to recapture that contact. The materials now that are out really in essence are not really packable truly, so you have to rely on a good, I think, sectional matrix. I find the Paladin system personally to be the best that works in my hands, and we use it routinely. And I rely on that because it has a nice biconcave and convex type of bioanatomy. It really helps to recreate that proper contact. And I think when you marry that with the proper ring selection, there's two different types of, the universal or the narrow ring. I think when you place it in there and a wedge that helps seal that gingival box, helps round that and brings that concavity up and out of that gingival kind of profile, I think you can have win-win. These materials will have to flow into that, and you have to rely on that separation that the ring creates along with that Paladin matrix system. So in essence, you really can't get the flowable to create the contact. You get the matrix to form the contact, and then you place your flowable because you can rely on the ability of it to adapt. Another great question, how long do you cure from the buccal and lingual? I like to cure, again, 20 seconds from the buccal and the lingual. So say, for example, in a class 2, I'll have exactly 60 seconds of curing. We'll go ahead and cure occlusally 20 seconds on the final capping layer, and then we'll wrap around and go to the buccal aspect, wait a couple seconds, 5 seconds or so, and then cure from the lingual aspect as well. So so when I say that total 60, that will be the final cure. Again, you're going to consider if you have a bulk fill material that you're going to place, you're going to go ahead and cure that for 20 seconds, and then go ahead and do your capping layer, another 20, buccal 20, lingual 20. That will be a total of 80 seconds. Another good question. Does the matrix band block the curing when curing from the buccal and lingual? If you're using a metal matrix, certainly it will block the curing. So what you're going to want to do is remove that complete matrix, just disassemble that sectional matrix or a Tafelmayer, whatever you're using, and then go ahead and properly cure. If you're using a clear matrix, certainly, then the light curing availability and that energy would allow that to happen and go through with that. I have another good question here. What kind of liner or base material do you like to use? I personally, if I have to use a true a liner, I go to, right now I like Theracal, and I find that to be a very, very excellent product. It's a light curable product, easy to place, and I've had very good success. Plus, it's very radiographically sound. So again, you go back to those values of radio opacity and how you can identify those things, and that's really, really important. Another very good question. Are the bulk fill materials more translucent for the depth of cure? Yes, they are. Their formulations have traditionally, initially when they started, they were very translucent. They are becoming a little more opaque in the aesthetic quality. So I think when you're working with maybe something in, say, a class 2 that would maybe be perhaps on a premolar in the facial aspect, buccal aspect that you want to mask, make sure that perhaps you don't have the bulk fill going exactly out to that facial or buccal aspect. Perhaps use a composite, traditional capping composite to place a little bit of that so you can block that. But these materials do tend to have some translucency to them, and that is definitely married to the factor that they have to have the depth of cure in them. Another good question from Anita here. Do you cure the flowable composite layer or leave it wet before placing your next layer? I want to go ahead, when I place my flowable composite, I don't directly like to place it. If I'm going to just use a regular flowable composite, say for example, say a 0.5 millimeter to 1 millimeter layer, and then place my composite, I'm going to go ahead and place that flowable first, and then I will follow, I'm going to cure that, and then I'll follow that with the next incremental composite layer. There's some great questions here. Here's another great one here. Do you know what the shrinkage difference between bulk fill and packable composites? That's a really great question. What you need to drop back and think about is when you look at what is packable, it's going to have more viscosity to it. And due to that viscosity, often the properties change, and so the polymerization shrinkage sometimes can be higher. And depending on what materials you're comparing, you really need to look at those values and really consider what the research shows and what has been found to be sound in comparison. So you really need to look at apples to apples when you're comparing and choosing these materials and understanding how they work and what they bring and value of polymerization, shrinkage, and stress, especially if you're doing the bulk fill type techniques or methods. Have another great question here. Do you use glass ionomer? And if you do, are you doing a sandwich technique for the subgingival margin? Yes, I do place glass ionomers. I believe in them. I think they're a very underused restoration choice, and I think they have very, very sound research and clinical just advantages. And I do like them for subgingival margins, and I think they're very, like an open sandwich technique, and I think that's probably what you're referring to, where you place that initially and raise up that proximal box, and you can go forward with traditional type composite placement. Another good question here. Do you still use flowable interproximally with a bulk fill on a class 2 preparation? I'm going to rely, when I'm doing a bulk fill, I'm going to rely just on that bulk fill and its properties to be placed, and place that into that class 2 preparation. I will not use a separate flowable whatsoever. I rely on only the bulk fill. I'll place an adhesive, light cure, place the bulk fill to the 4 millimeter depth or whatever depth I know to allow a 2 millimeter capping on top of that, and I've got a very, very good sound restoration. So there's really no need to place a separate or individual flowable underneath a bulk fill. Now, another good question. Sometimes taking the matrix off can cause the gums to bleed. Does that compromise the restoration? And I think that's really very important, because I think you need to look at sometimes different wedges and different systems that are out there. I find that the Paladin system has a very, very kind wedge that when it's placed in approximately, it really rides on the papillae nicely. It's kind of a wave design. It's a bead design that goes and slips in properly. It seals and keeps things very, very isolated, but more importantly, it's kind of that papillae, so we really do not have a lot of irritation. And I'd really encourage you to try that system if you haven't done that, because it really does work, and you find that you don't have very much violation of that aggravation, gingival irritation whatsoever. So can it compromise if it's not properly sealed or properly cured? It surely can. So again, working with these systems and really keeping things in line and really tweaking your protocol really helps every step and stage of the way of the process of placement. Another great question. Do you wash off the chlorhexidine? No, I do not. We allow that to stay in the preparation for a minute, and then we suction that out of there. We'll use a place of suction, high-vac suction on the preparation, and kind of seal our fingers around it and allow that on there for about 2 seconds, and then we're ready to place our adhesive application. Got a bunch of great questions again here. I'm just reading through all these wonderful stuff. What kind of bond are you using? I was using Prime and Bond Elect on both of the cases that you saw here clinically. Another good question from Nicole. Do you ever find that the transition between the bulk fill and the cap increment cause issues? No, I've not. And I think what you need to realize here is that once you've placed your bulk fill and it self-levels, which is truly important, you're going to cure that for the right amount of time. You can directly place your capping layer. And I have not found any issue whatsoever. I think if you immediately go to that, you're not going to have any voids. You're not going to have the contamination issue. Really, you cut down on what chances of interruption could happen when you're building that restoration. Another great question from Ray. What type of composite do you use for the cap? How thick? Great question. So going back to that protocol of a bulk fill, if you traditionally, let's say, have a 6 millimeter depth of restoration, you can apply a 4 millimeter bulk fill increment And then these require an absolute 2 millimeter occlusal cap. In the case I was using, or both of those cases, I was using TPH Spectra, a low viscosity material, and they also have a high viscosity. Personally, I like the low viscosity. And go ahead and you're going to light cure that, but they need to be capped with an occlusal capping of 2 millimeters of depth. So again, go back to that kind of that periodontal probe that I was showing you and kind of get an eye on sighting that, and use that little rubber gauge if you need to kind of measure the depth of the preparation. And the key is really not to violate the depth of what these materials work at and function. So again, measure it and kind of get a good idea on that level, and you'll have great success. Another good question here, do packable composites still have superior shrinkage? And when we were talking about that earlier, again, go back to the science on these materials and really, truly see what's out there in the research, see what's been done to really show their performance and understand, sometimes if it has a higher viscosity, it might be more challenging in that polymerization, shrinkage, or stress, and it might have more ability to not adapt as well too. So again, I like to use materials that I know that have that adaptation value to them, quality built into them, depth and light cure, and performance. And that way I have a good measure of knowing confidently I'm not going to have voids, I'm not going to have anything that I have to rely on my own tool to make sure there's no error, no void, no little air entrapment, because all of that does play out down the road. And you can see here again, you go back to postoperative sensitivity, bonding, micro leakage, etc. There can be failures, and there's a lot of steps that can be violated along the way. So again, I think the more consistent and the more effectively and efficiently you can place these composites, not cutting corners, I think you have a better win-win, because you're not introducing other vulnerabilities or other risks that could really play out down the road for a failure of a restoration. Another great question, why do I apply the chlorhexidine? I like chlorhexidine because there's some studies out that show and indicate that this property, the MMPs, can be, you're working with chemistries that can get the collagen fibers and everything ready to accept that adhesive application. And there's some good science out there that you can really surf and check out, but it really can help the bond strength, I think, and keep a very good viable restoration adhesively, and keep that interface in its best capacity to have a good success long term. So check into that. There's some great science behind it, a couple of great articles out there about that too. Another great one, I can use bulk fill, or can you use a bulk fill as a core for a crown prep? Absolutely. I think SureFill SDR is an excellent choice for a core for a crown prep. I like to use it sometimes. Often we might have a small undercut when we're prepping, or we might have a little divot and we make sure there's no undercuts. It fills in perfectly for those areas, again, because of its flowability and because of just how it performs in its adaptation. So really, really nice. Another good question, have you ever encountered leakage between the bulk fill and the cap? No, I have not. And again, I think this goes into the light curing and any possible or potential introductions of contamination. I think if you keep your protocol and your placement succinct, you're not going to have that and have that happen. So all very good questions and great stuff here. I want to thank everyone for their time. And please stay on the queue here so you can go ahead and get your continuing education credit. And thank you for your time. I really appreciate all these questions. Super great stuff. And have a great rest of your day.
Okay, I will go ahead and wrap this up as it is 8:30 Central Time. If you do have any questions that the speaker did not get to address, I will go ahead and email them to her, and possibly she can respond via email when she gets a chance. And I will go ahead and email the CE instructions to obtain your certificate of attendance. I'm going to email that out within the next 10 minutes, so watch your inbox for that. You'll be directed to the Catapult Group website to take a short CE quiz, and then you can download your certificate letter. I would like to thank the sponsor for this evening, Dentistry Restorative, and a big thank you to Dr. Lori Trost for her time and effort this evening. Thank you everyone for attending. Have a great night.